Good morning and welcome to virtual boot camp. So we're doing some predictor prep this morning. Going to go over some topics to review. The first one that we reviewed, we already did this, but I'm going to go over for the benefit of those watching this recording, transmission-based precautions. You have universal precautions or standard precautions, which means everybody's got something, right? In other words, if you're going to touch blood or body fluids, you wear gloves for everybody, okay? If you're only doing vitals or something like that where you're not going to come in contact with blood or body fluid, then you don't need gloves, right? Human touch is important. You have contact precautions, where in other words, you'd have to come in contact with the infectious stuff like C. diff, the stool. Vancomycin-resistant enterococcus is found in urine. That is another multi-drug resistant organism. It's a superbug like MRSA, but it's found typically in urine. It's called VRE, vancomycin resistant enterococcus. That would be contact precautions, okay? MRSA, if it were in a wound, would be contact. If it were respiratory, it would be droplet, right? And when we talk about airborne precautions are 3 diseases: measles, tuberculosis, varicella. I want my MTV. And so N95, fitted particulate respirator for the nurse, surgical mask for the patient, negative pressure isolated room for the patient. In other words, they can't share a room with another patient even if they have the same disease, okay? Where with the other types of transmission-based precautions, they can do that. 2 people with the same type of pneumonia, droplet, they can share a room. 2 people with C. diff, they could share a room, but not with the airborne diseases. And also remember, measles is also called rubeola. So you have measles, rubeola, tuberculosis, and varicella, which is chickenpox. Varicella is airborne, but when the rash is erupting and oozing, it's contact also. So remember that, okay? All right, the next topic was about childhood cancer, pediatric cancer, and neutropenia and neutropenic precautions. So neutropenic precautions, does anybody want to tell me what is neutropenia?
A low count of the neutrophils or something like that.
Well, what are neutrophils? What kind of blood cells?
White blood cells.
White blood cells.
White blood cells.
Mm-hmm.
Cancer.
Okay, so the white blood cells are low, not because of the cancer. Why does this child have neutropenia? Why does somebody with cancer develop neutropenia?
Because of the treatment.
Thank you. Because of the chemo and or radiation. Chemotherapy like methotrexate, radiation therapy. Though both of those types of things are myelosuppressive. They suppress bone marrow. When your bone marrow is suppressed or depressed, then it can't make blood cells, which means it can't make white blood cells, so you can't fight infection. It also can't make red blood cells and platelets, so you're at risk for anemia and bleeding as well. Not because of the cancer, because of the treatment. If there's any questions about cancer specifically, just watch the video lecture on cancer. I think it's chapter 11. Okay. So now we have a child and they are neutropenic. With an adult that's neutropenic, we can tell them if you get a sore throat, any signs and symptoms of infection, notify the healthcare provider immediately, right? But with a kid, it's going to be a little different. What types of things are you assessing on a child? And when you think about it, just say to yourself, what are the things that we have that protect us from infection other than our white blood cells?
Your body.
What defense mechanisms?
The
skin. Your skin, your integumentary system, is your #1 first line of defense against letting pathogens into your body. That's why we're always screaming about compromised skin integrity, right? Because the minute there's a compromise, it's an opening for things to get in. germs, pathogens, right? Bacteria, viruses, spores, mold, fungi. So with a kid, you would be looking at their skin. Little kids, even kids with cancer, they still want to play. So if the kid has any open abrasions, skin, knee, that would be a cause for concern, right? Right. So that would be something that you would be concerned about and you would be assessing. When you look at these questions, your brain has to think through the process. This is the part that I keep yelling and screaming and crying about with all of you. It's understanding content, not questions. The questions are irrelevant. But if you understand everything there is to understand that I just explained, like the kid with neutropenia, why are they neutropenic? It's not the cancer, it's the treatment. What does it mean? What kinds of instruction? What things are we assessing for? Then you can answer any question you get, right? That's the point. So what are neutropenic precautions, generally speaking? What kinds of things do we say? If somebody's on neutropenic precautions,
No
what do we
fresh
tell them?
flowers.
Wash your hands. Wash your hands. Stay clean.
No
Avoid
fresh
big crowds.
vegetables.
Well, you're all, listen, washing your
crowds.
hands, listen, washing your hands, hand hygiene is a given. Neutropenic precautions over and above basic precautions. I heard no fresh flowers.
Yeah,
No
no
raw
fresh
fruit,
flowers.
Avoid
No
large
raw
crowds.
meat.
Right, so no fresh fruits, no fresh vegetables, no fresh flowers, no live plants, no uncooked or undercooked food. Right, and no crowds, avoid crowds. If they have to go somewhere, they should wear a mask, right? Because we're protecting them from us instead of the other way around. We don't want that person to get in contact with any pathogens, because if they get an infection, they don't have any white blood cells to fight it off, right? That's immunocompromised. A patient that's immunocompromised does not have white blood cells, either because of cancer treatment or because of another disease like HIV, or because of long-term use of corticosteroids like prednisone, right? There are many different reasons why a patient would be considered immunocompromised, right? But you have to be able to think it through. So with a child, you would say to yourself, well, what would I be worried about if the kid can't fight off an infection? Ooh, if they have any cuts or, scratches or scraped skin, knee, that's a problem. They could get an infection right away. Does that make sense to everybody?
Yes.
Yes.
Yeah.
Okay, all right, okay. And everybody put a
Yeah.
smile on your faces, because I don't hear smiles in your voices, all right?
Cheese.
All right. All right, point taken. Evidence-based sources of information. I am always and forever yelling about evidence-based research, okay? Evidence-based research means that there have been multiple studies, not one study. One study does not make something a fact, right? We need multiple studies that are heterogeneous, in other words, that involve all different samplings of the population, in order for all of the medical community to come together unanimously and go, yep, the evidence is there, and this is the way we should be doing this procedure, or whatever, right? So evidence-based sources of information are peer-reviewed journal articles, or a medical textbook, a medical dictionary, right? The Merck manual, right, is a medical, it's a medical dictionary and a medical encyclopedia, basically, right? These are sources of credible information. Not a website, not Facebook, not Instagram, not WebMD even. Professionals only refer to other professionals to get their information that is credible. Okay, so make sure you understand that. There was a question, and there's going to be a question on the next one about evidence-based sources of information or evidence-based research or something about it. So make sure you understand it. Does anybody have any questions?
No.
Okay.
No.
No, all right. Okay, moving right along. Let's see. Ergonomic principles. Repositioning a client who is immobile. 25%. Woo! Okay. So, what do we know about ergonomic principles and repositioning immobile clients? So, if a patient is unable to move, how often must we move them?
Every 2 hours.
Every 2 hours.
Minimally every 2 hours. And what does that prevent?
Ulcers.
Skin breakdown.
Decubitus ulcers, aka
Skin
bed
breakdown.
sores. Right, that's skin breakdown. Skin breakdown, we're talking about decubitus ulcers, right? So if they're immobile, we're going to reposition them every 2 hours. What types of positions should we place them in, for example, to take pressure off of bony prominences? How would we do that?
Their head slightly elevated. High fowlers.
High
Low
fowlers
fowlers.
increases pressure to the
Low
coccyx.
fowlers.
Like 30-degree.
So like a
Semi-fowler.
a semi-fowlers, low fowlers is fine, you know, slight, like a 30-degree angle, 15-degree angle is okay. High fowlers is not good because all the pressure is on the lumbar spine and coccyx. So they're going to be more prone to break down in that area, right? When we're repositioning a patient in the bed, what must we first do with the bed?
Rise
Up
the
or
bed.
down?
Rise it up to your
Up.
level.
Lock the
bed-
wheels.
Yeah, of course, lock the wheels. Yes, thank you. The bed should be brought up to its highest position so that you're not bending over, right? Okay. And the one thing, don't forget to put the bed back down when you're done, right? So the bed should be raised to the highest position. If we have to move an immobile patient, what is the thing that we should avoid? Let's say we have to pull them up in the bed. How do we do that? Do we just take the pull sheet and just pull them up?
No.
No.
Well, help me out. What do we do?
You use your lower extremities to help pull them up.
But what you always use your legs. So when we talk about stance, you should never bend at the waist, right? You should always
apart.
Your feet should be as far apart as your hips. You should never have your feet close together. You need a wide stance because that gives you a good center of balance. And your knees should be slightly bent, right? So that believe me, you do this for some years and you're going to get a bad back if you don't do things right. So when you're moving the patient though, does everybody know what a draw sheet is?
Yes.
Yes.
So when we use a draw sheet
Yes.
to move an immobile patient, how do we do it? Do we just pull?
No,
No.
you need another
You, like,
person.
kind of
You and another
lift
person to be like aligned with the client so that way when you go to pull them up, you both are doing it at the same time.
Lift and pull is what I'm looking for. You're on the right track, la la la. I'm gonna call you that from now on, just so you know, la la la. But you never just pull or drag because you will shear the patient's skin. So they must always be lifted and then pulled up. Understand?
Yes.
Pillows under bony prominences, right? Let's see, what else? Repositioning a patient. Do you guys know what a log roll is?
Yes.
Yeah.
Let me put it this way. Does anybody not know what a log roll is? Okay,
yeah.
never mind. A log roll is when you have a patient that say has, for whatever reason, maybe there's a fracture, but we don't want them to move. We picture a log, right? A big log. You want the patient with their arms at their sides and their legs straight out, and you want them flat on the bed, and you literally want to roll their whole body together so that there's no twisting of the body. That's a log roll. And there are certain instances where that would be appropriate. Like I said, if there's a C-spine or lumbar spine fracture or injury, right? You don't want twisting going on. So that's a log roll. Repositioning every 2 hours, bony prominences. I can't think of what else. I mean, there should always be 2 people, never drag the patient, always lift and pull for repositioning. Should have 2 people. And I think that covers that as much as I can. Does anybody have any questions about repositioning?
No.
Okay. There were quite a few maternal, newborn, ped, not quite a few, I think there were 10, where it was below 50%. Let me get that. Let's see. Come on, open. Sam, stop it. Excuse me. Okay. Well, actually, let's just go to mental health because we're 1, 2, 3, 4. Okay. So under behavioral management, there was one about suicide, identifying the client who's at the greatest risk of suicide, 32%. So suicide, suicidal ideation, risk for suicide. When you're assessing someone, they won't necessarily come out and say, I want to die, I'm going to kill myself. They may say things that are more subtle. They may say, you know, nobody loves me. It doesn't matter if I'm here or not. You know, subtle things. If a patient suddenly becomes socially isolated and withdrawn, that's worrisome, right? Who could think of anything else that would make you be concerned about someone having suicidal ideation? What other
Giving away
behaviors?
their belongings.
Giving away precious belongings. When I start giving away my antique books, you know it's a wrap, all right? It's a wrap. So, you know, everybody has things, something that they, you know, value or treasure. Doesn't even matter if it's worth money, it's just maybe sentimental. When they start giving that stuff away, that's a warning, right? Does anybody have any recollection about the suicidal question? No? No? Anybody? Nobody. Y'all got amnesia?
No, it had said something about the client was pacing back and forth.
That was the aggression.
No, that was a different question.
Yeah, that was the aggression. We're going to get to that one next.
Okay.
But I know one answer, it said, why do you want to hurt yourself? And then I can't remember what the other questions were.
All right. Well, here's the thing. So
Yeah, one of them said fight or flight or something like that. Fight or flight.
That's for bipolar disorder. It was asking, was it
okay.
flight of ideas?
Oh yeah, flight of ideas. Yeah, never mind.
right. So, all right, let's address one thing at a time. So the suicide question. With suicidal ideation, regardless of what the question was, it doesn't even matter at this point. Just understand what, number one, with any therapeutic communication or psychiatric or mental health question, you never ask a patient a question starting with the word why, because it puts them immediately on the defensive, right? Why are you not taking your meds? Why do you want to kill yourself? Right? So you would immediately eliminate an answer if it starts with the word why. You don't. Tell me the reasons you are feeling like this. Help me understand what's going through your head. You know what I mean? There are lots of ways to word things without making it sound accusatory. Why are you not doing that? The word why automatically makes people feel some type of way. So if an answer starts with why, it's probably not the right answer. Probably, right? Yeah, okay, there you go, la, la, la. So somebody's suicidal or you even have an inkling, you would never leave them alone. Not even for a second. You would go through their belongings, right? When I worked at the Lighthouse, I had a 16-year-old boy hang himself. So, you know, if somebody really wants to take themselves out and they're serious about it, they will find something, so you can't leave them alone for a moment. And that's about the most I can tell you about suicide. And with suicide also, suicidal ideation, the next question, if somebody says they're having thoughts of hurting themselves, the next question has to be, do you have a plan? How would you do it? If they have a plan, you have a problem, right? A plan, you know, some people just say, you know, I'm worthless. I don't want to live anymore. Do you have a plan? I didn't really think about it. You have some time with that patient. If somebody says, I have a gun in my nightstand and it's loaded, I just need to come up with the courage to put it in my mouth. That's a problem. And there is a thing called a suicide contract. Excuse me one second. Sorry. There is a thing called a suicide contract. And these kinds of things are used kind of a temporary, it's like a Band-Aid on a hemorrhage. You make a contract with the patient. Patient will agree, a written contract. Patient will agree not to hurt themselves for a finite period of time, say 24 hours. And you in turn give them something. So maybe they want an extra smoke break. Maybe they want they want their girlfriend to come visit. Something, right? It is a real thing, a suicide contract. And you may see that on the boards. So just wanted to throw that in there. The other mental health questions, one had to do with pacing or something like that. Give me 1 second. 1 second, where is it? Get everyone except the one I want. Okay, so responding to escalating aggression. Responding to escalating, that's not the pacing question, I'm sorry. That's different, that's under anxiety disorders, behavioral interventions for someone who's pacing. But this one is anger management, responding to escalating aggression. So, again, let's talk about the content. And that one was like 20%. If somebody is becoming increasingly aggressive, you have to say to yourself, number one, if you're in a facility and you have one client who's becoming increasingly aggressive, if there's a chance that the safety of the other clients is jeopardized in any way, that's got to be your first priority, right? Because let's say you have a client that's wanting to beat up the other clients. This is funny, I had a guy who was 90-something years old and smoked Pall Malls, filterless cigarettes. And he was as healthy as a horse, but he had the worst dementia ever. He was a boxer, like back in the 1930s or something. And so he was all day long, he was getting ready to go in the ring. He was ready to box. And he would just walk around and like, just randomly, he would think that one was his sparring partner, try to hit him. I mean, we had to separate him from the general population. You know, you have to consider the safety of the patient that is aggressive, the safety of the staff, and the safety, first and foremost, of your other patients or residents, okay? So, and when you respond to someone who's aggressive, the worst thing that you can do is escalate, right? So how do you de-escalate? If somebody's going, I had enough, that's it, I'm gonna kill everybody in this goddamn place, right? Right, what would you do?
Try to take them for a walk.
The first thing that you wanna do is you wanna just try to get them in a firm but calm voice. I'm gonna pause recording for 1 minute, this is work, so hold on. Okay, we are back, so let's talk about some other topics. Like I said, we'll get through mental health first. Stress and defense mechanisms. Identifying defense mechanisms. That one was like 45%. So I have a cheat sheet, which I'm going to pull up right now, on different types of defense mechanisms like transference and rationalization, et cetera, et cetera. So we'll talk about those for a minute, and I will, if I didn't already, I'll put the cheat sheet up on Teams for everyone so that you can see it, okay? Defense mechanisms, here we go. And I will share my screen. There it is. So everybody can see that, right? So defense mechanisms, we have rationalization, which means that, you know, you're going to use an excuse to explain something. My teacher hates me, that's why I failed the test. That's rationalization. Smoking only does damage to other people's lungs, not Miss Mary's. Rationalization. Okay? Displacement is taking how you feel about one person or thing and then directing it towards someone else, right? So you have a terrible day and you come home and scream at your kids and you kick your dog, right? It's not their fault that your day sucked. That's displacement. Regression. Regression is something that's a really strong defense mechanism with children, where they will actually regress or go back to a different level of development. So, you know, a kid that's already potty trained and there's a stressful thing that happens and suddenly they are no longer potty trained. They're having accidents left and right, right? Or adults, they give you the example, an adult has a temper tantrum, road rage, they're stuck in traffic. Introjection is taking on the attitudes of other people without any thought, right? Well, you know, I like Cardi B and what she thinks about politics, so I agree with her, right? So, but without giving it any thought or examination. In other words, you don't even really understand it, but you're just gonna think whatever she thinks and agree with it. Reaction formation is, it's like being passive aggressive. When you think of reaction formation, just think of passive aggressiveness. So I really don't care for you and I'm mad at you because of what you did last week. But instead of saying that, I'm just going to be like, oh no, I love you, honey. You're the best. But meanwhile, I'm really pissed. Okay. So you're behaving the opposite of how you really feel and not being honest about your feelings. Repression. This is a very common one. If there is an episode, an event that is somehow traumatic, what we do is we just go, you know what, I'm going to take that and just squish it. It never happened, but it did happen. But if they repress it, just say, make believe it never happened. I don't want to talk about it. I don't want to think about it. The problem with that is it's still there, right? And if it's not addressed, it will cause psychological issues down the road. And then sublimation, right, is taking a thought that's socially unacceptable and transferring it into something that's an acceptable action. The one that I like to use is somebody is fascinated with dead bodies. So they become a mortician, right? Because we need funeral parlor directors, we need morticians. And so they're fulfilling that unacceptable thought in their head by turning it into something productive, and they're making money doing it too. So sublimation. I will put the defense mechanisms up on Teams for everybody. Does anybody have any questions about any of these defense mechanisms? Anything you want to share? Questions, comments, anything? Nope, crickets? Okie doke. All right, the next topic is sensory perception, caring for a client with a hearing aid. So let's stop sharing for a minute. When a client has a hearing aid, a couple things to know. Number one, make sure it's in and it's on. If you ever hear like a right, it's feedback, the volume should be turned down a little bit. That's what that is. If they say, I can't hear, maybe it needs batteries, right? Whenever you're speaking to someone that has any hearing impairment, if you say something to them, you speak clearly and in a low tone of voice. Older folks, the first thing that they lose with regard to hearing is high-pitched sounds. So for girls that have that real high-pitched sound, they're not going to hear you. My mother had no hearing in one ear. So I grew up my whole life having to talk in a low voice and slowly in a way that she could hear. So you are going to speak slowly. And here's the thing. If they say, this is my good ear, no, you always face them. You don't speak into an ear on one side or the other. You need them to be looking at you. And you want to speak slowly. And then if you say something and they say, huh? Rephrase it. Do you want something to eat? Huh? Do you want something to eat? Are you hungry? Rephrase the question. Okay, that's trying to think if there's anything else with hearing impairment. If all else fails, there are communication boards. Speech therapists use these all the time. They have dry erase boards where if the patient is able to write, they can write what they want, right? Or you can write to them so they can read it. They have communication boards that have things like pictures of, there's food, there's a bathroom, there's outside, right? Like, what do you want? They can point to it. So when it comes to hearing impairment or speech impairment, sensory impairment in general, make sure you understand different ways to communicate with people that have any type of sensory impairment. In other words, visual or hearing, okay, or communication speech. Okay. And remember, the word dysarthria means difficulty with speech, right? And aphasia is can't talk. And then remember, and don't confuse that with dysphagia. If it's AGIA, that has to do with swallowing. If it's ASIA, that has to do with speaking. And they
This
can
S
have
in speech, the G for swallowing. Stop, boy.
what? Say that again, la la la. Sorry.
I was saying the way that I always had remembered it was the S in dysphagia for speech.
Yeah,
like
there
for
you
the
go.
speech, and then the G, like, because the other one is for
Right.
swallowing.
There you go. And that makes sense too. Dysarthria, I don't even have any kind of cutesy little mnemonic thing to help you remember that. You just have to remember that dysarthria is difficulty speaking.
Speaking.
Yeah. I mean, I did not write the Latin language, so I, can't kill the messenger. And make sure that you all know phrases, aphasia, without speech, not able to speak. Is it receptive? In other words, are they not understanding speech? Is it expressive? They cannot speak. Or is it global, which is both expressive and receptive? Okay. Any questions about sensory impairments? Okay. You guys just aren't awake yet. All right. So now let's see. We have pressure injury, wounds, and wound management, performing a wet to dry dressing change. Can anybody tell me why we use a wet to dry? What types of wounds? What is the point of a wet to dry dressing? Anybody know?
It helps with debridement.
Still, one person keeps on answering every question.
Sorry.
No, don't be sorry. I mean, it's good that you know the answers, but like, anyway, we got 11 other people. So a wet to dry dressing is typically used for mechanical debridement. If a patient has a wound and the wound bed is either covered with slough, which is a thick yellow looking, it's not pus, it's not purulent exudate. Slough is different. It's a little harder, right? And it covers the bed of a wound and it makes it difficult for the wound to heal. Or if it's got eschar, necrotic tissue, hard black tissue in the wound bed, the wound will not heal. Okay? When you look at the bed of a wound, it should look red and grainy, like you just cut open a steak, right? Beefy looking. That means that there's good blood flow and good oxygenation to it and it's healing. If there's slough or eschar on it, it's not going to heal. So we need to debride it. Debridement is the process of removing dead tissue to allow good tissue to heal. And so there's mechanical debridement, chemical debridement, and surgical debridement. Mechanical debridement is a wet to dry dressing. We take gauze, we wet it with saline, apply that to the bed of the wound, cover it with dry gauze. We usually will wait 12 to 24 hours. When we change the dressing, you remove the top layer. When you remove the layer closest to the wound, it'll pull off some of the dead tissue, okay? That's why it's important to medicate your patient for pain 20 to 30 minutes prior to a dressing change, okay? Because it's a little uncomfortable, all right? So that's why we use a wet to dry. We might as well talk about wounds too in general. So when we talk about wounds, dermal ulcers, which include pressure ulcers, decubitus ulcers, bed sores, right? Stasis, venous stasis ulcers, and diabetic ulcers. Dermal ulcers require moist wound healing. That's in my lecture too on integumentary. Wound care is not sterile, typically, unless it's a very specific type of wound where it necessitates it being a sterile procedure. Wound care is typically a clean procedure, not sterile. So you want to have clean gloves, not sterile gloves. You want to know how to assess the wound, which, like I said, you're looking for the wound bed, if it's an open wound, to be grainy and red looking. You're looking for approximation of edges of the wound. That means that the edges are coming together, right? So the wound is closing, right? You're looking for signs and symptoms of local infection. Local, in other words, at the wound, would be erythema or erythematous streaks coming away from the wound, or increased redness around the wound, pain, increased pain at the wound, and then any type of foul smelling, purulent exudate that's maybe green or yellow and viscous, right? You got to know those words too. Viscous is thick, copious means lots of it, okay? Approximation means the wound edges coming together. Granulation is the bed of the wound being nice and grainy and red and beefy looking. Eschar, the black dead tissue. Slough, thick hard yellow tissue, okay? You never use wet to dries or any dressings that are on for greater than 12 hours on a diabetic, by the way, because you want to be able to see the wound. So you would never put a dressing on a diabetic wound that is ordered to stay on for 24 hours or more, right? Because you need to see that wound, because they are compromised because of microvasculature. In other words, erratic blood sugars, and they've got probably peripheral diabetic neuropathy. So they're not getting good blood flow, or they have problems with the feeling and sensation. So the bottom line is that you always want to be able to visualize a diabetic's wound. So that's going to require a dressing change that's more frequent. But dermal ulcers in general, moist wound healing. And I think that's all I got about wounds. Oh, and undermining. Undermining means there's a gap under the edges of the perimeter of the wound. So the wound looks this big, but then when you take your cotton tipped applicator to go around the edges, it goes in and up. It's underneath. So that's undermining. And tunneling is where there's an actual tunnel that goes, that's hidden inside the wound. Like if I go down to 6 o'clock, I can go all the way down in like 4 or 5 centimeters. That's a tunnel. And that means that the wound is going to open up and be way bigger, right? So tunneling, undermining, I think I covered all the terminology, if you will, that is accompanies wounds. Okay. Any questions?
No.
Nope. Okay. Home safety, electrical hazards, decreasing electrical hazards. So when we talk about home safety and hazards that are electrical, if you ever get a chance to do home care, you will see the crazy things that people sometimes do. Extension cords should never be run across the room, under a throw rug, anything like that, because that's a hazard, right, for tripping. One outlet should not have like 4 extension cords plugged into it. So they've got 6 or 8 appliances going to one outlet. That's a problem. It could start a fire. There should never be any fraying, right? Or anything, on the electrical wire. When you remove a plug from an outlet, you never pull it by the cord, okay? You pull it by the plug. I don't know what the question was, but I do recall having seen something about pulling the cord near the plug or something to that effect. You wouldn't pull it near the plug. You would pull the plug. So in other words, just to really, Here is plug to my computer. This is near the plug, wrong. This is the plug, right? Okay, so make sure you know that, okay? And you should do that in general terms, because over time, if you pull it by the cord and yank it out of the wall, you're gonna disconnect the wiring that's within the plug, and then you're gonna have a fire hazard. And when it comes to home safety, you know, well lit, of course, I can't think of anything else when it comes to electrical safety. If they have oxygen in the home, oxygen tanks should always be stored in an upright position, never laying on their sides. There should always be no smoking signs, like everywhere, to make sure that other people are aware, right? And colored tubing for the oxygen as well, so that the patient doesn't trip over it if they're on continuous O2. All right, so that's that. Let's see what else we got. Quite a few. Did those already. Let's get rid of that. Here we go. Intravenous therapy. Findings of peripheral IV infiltration. Let's talk about that. That was 25%. Okay. Peripheral IV infiltration. There are words like infiltration, extravasation, right, that are related to IVs. When you have a peripheral line in a patient, right, let's say there's a peripheral IV here, okay, it's supposed to be going right to the vein. The little catheter is inside the vein so that medication or fluid or whatever you're running is going into the vein, into the venous system. If there is an extravasation, extra, outside of, vasation, outside of the vessel, that means that somehow the catheter is no longer actually in the vein. So it dislodged, it moved, it punctured through the wall of the vein. Could be lots of different things, right? So with extravasation, that means that now whatever fluid's running is now not going into the vein. It's just going into the subcutaneous tissue. So it's going to feel cool to the touch, not warm. And infiltration, which is this basically this almost the same thing. It's what happens. It's the fluid is now, the IV is extravasated, and the IV fluid or the medication or whatever is infiltrating subcutaneous tissue, right? So there's going to be swelling, right? It's going to feel maybe firm, cool to the touch, because the fluid or the medicine is now just going into the tissue. And so, of course, you know, priority nursing intervention, stop the infusion, take out, remove that IV and start a new line. And when you need to start a new peripheral IV, their peripheral IVs are always started the most distal point, and then you work your way proximal. In other words, so don't use the hand because that hurts. People use the hand when they don't know what they're doing, FYI. You start here. Got a problem with this one, or it's time for it to be changed, then you go above it. You can go above it to the antecubital space if you have to. Antecubital space is a bad idea too, because every time they bend their arm, guess what? They're going to have an occlusion. The pump's going to be beep, 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 beep. Okay? So does everybody understand what extravasation and infiltration is?
Yes.
Okay.
Yes.
Thrombophlebitis. So the word phlebitis means inflammation of a vein. Just think of phlebotomy. Phlebotomy is drawing blood out of a vein, right? So phlebitis is inflammation of a vein. Thrombophlebitis is a clot that's causing an inflammation of the vein, right? And so that can happen too with peripheral IVs. But in that case, you're going to see erythema and warmth at the site, right? You might even see a streak along the vein, a red streak. That is thrombophlebitis, okay? When we talk about the parts of an IV catheter, actually, here's what I'm going to do. I'm going to pause the recording and I'm going to go grab an angiocath, because you need to know the parts of it. there have been questions about, you know, you're assessing a peripheral IV site and you find blood in the hub. What do? You guys know what the hub is?
Yeah, that's normal, right?
Right. But does everybody? So let me go grab one. I'm going to pause for 1 second. Pause. Okay. So this is an angiocath, or an over the needle catheter, or a peripheral IV, or a HEP lock, or a saline lock. It's got a lot of names, okay? But all of those names mean the same thing. They're referring to a peripheral IV. They're all color-coded, by the way, and the colors are universal. You can see that this is blue, right? And it tells you 22 gauge by 1 inch, right? But a blue is always a 22. Yellow is 24. Anyway, when you open it, what you have is, put this back together. This is what comes out, okay? And when you remove the cap, what you have is a plastic catheter, but there's a needle inside. This is a safety catheter. So when I pull, once I get it into the vein, I pull back and the needle pulls inside this plastic right here. And the only thing that's left in the patient is this. And this is attached to tubing, okay? So this is actually what's in the patient's vein, that little flexible catheter, okay? And the hub is, I can put this back, when you are accessing the vein, the hub is this part right here, and you'll see a blood return, which is like, yay, I'm in the vein. So blood in the hub is normal. It's good. It's a good sign. That means that you're in. So there's nothing to do about that. Okay. That's a peripheral line. And by the way, peripheral lines in facilities, if you're in a hospital, typically need to be rotated sites changed every 3 days, 72 hours. Okay. IV tubing and anything else to do with the IV changed every 24 hours. Enteral feeding tubing changed every 24 hours. I think that's that. PICC line, peripherally inserted central catheter. So in other words, it's going to the superior vena cava of the heart into the right atrium, but it's inserted peripherally. It's usually put in the upper arm right around here, okay? So it's a very long catheter, flexible like the one I just showed you, but long. It's got a long guide wire inside of it. So when they place it, now they place them under fluoroscopy. So the patient's under an x-ray machine and it's like, they can put it right in. I used to put them in people's houses, blind, right? So, and then we would get portable x-rays to come to the house to confirm placement. Crazy. So when a PICC line is placed, it's got to be confirmed that it's in the right spot, and the length of the catheter needs to be documented. In addition to the measurement of how much of the catheter is seen protruding from the entry site. Why is that important? Well, because these things can stay in somebody for 5 months, 6 months, 8 months, 10 months, a year and a half, really, a PICC line. And sometimes people get sloppy or whatever, and it can dislodge. So that's why every time the nurse does a dressing change, which is a sterile procedure, it's done weekly, and PRN, if the dressing should get wet or start to come off, they need to measure always to make sure that it has not dislodged in any way, shape, or form, and document the measurement. You can get blood from a PICC line, and you can put in more caustic types of medications, things like vancomycin, if the person has MRSA. Some medications are caustic, C-A-U-S-T-I-C, which means they burn going in. And vancomycin is like strong, antibiotic. And so that can burn going in. So we like to run that through a PICC line rather than a peripheral line. Chemotherapy and those types of agents are very caustic. So they're typically run through a port, also called a portacath, also called a mediport. an implanted, surgically implanted port goes into the anterior chest wall. The person's thin. You can see it sometimes bulging. It almost looks like a little pacemaker, right? A little round bulge. And what it is it's a central line, surgically implanted. And inside there's this round port with a rubber piece in the middle, and then a tube that goes from it into the superior vena cava, to the right atrium of the heart. That is a true central line. You can put chemo in there. That thing can stay in a person for 20 years, 30 years, 40 years. The only exception to that would be with a child. Anybody know why? They, if a little kid has cancer and they have a port that, when a couple years go by, they may need a new port.
They grow.
That's
They grow.
right. You'd be surprised. People don't put two and two together. They grow. So with kids, they're growing. They're not going to have, their anatomy is changing as they grow. So they're going to need a new port implanted. Sadly, I mean, that's another traumatic thing for the poor kid to go through. But anyway, that is a central line. So central lines, which the Mediport, Portacath, implanted port, they are accessed with a non-coring needle called a Huber needle. The needle is like a kind of a hook shape, and it's a sterile procedure where you would have to physically hold the port under the skin, access it with the needle, you get your blood return, clear occlusive dressing over the site, okay? So that you can only see the site of where the needle enters the port to make sure there's no infection going on. And that's a central port. Any questions so far?
No.
Okay. And all of them need to be flushed regularly. A peripheral line is usually flushed more frequently if there's not fluids going through it, simply because we don't want it to occlude, right? PICC lines are usually flushed before and after medications or weekly. And then a central line can be flushed monthly, right? So, or sometimes even less than that if they use heparin. So heparin can be used. It's a very low dosage of heparin. It's called a heparin flush. Heparin can be used to flush different types of PICCs and ports and peripheral lines. It just prevents blood from clotting in the catheter so that the patient, doesn't have a clot in the catheter. And I think that's it for IVs. Yeah, I think so. Okay. Moving right along, increased intracranial pressure, I believe, was the other topic I wanted to talk about. And just heads up, I've got to be done by 12. Okay. The other topic was, nope, did that one. Nope, wrong one. Where did you go? There you are. Oh, no, residual urine. So under urinary elimination, under therapeutic procedures, catheterization for residual urine, 40%. That one made me want to scream when I saw that, okay? Because I know I've said this a bunch of times. If you suspect that someone is experiencing urinary retention, they're not fully emptying their bladder, the doctor may tell you to get a post-void residual straight cath or catheterization. In other words, you're going to have the patient urinate, and then after they urinate, you're going to catheterize them to see what's left in the bladder. And that's literally, I saw the question. Right. So I don't know what went wrong. Anybody got anything? No, nothing? Grazie che ne frega.
I don't know.
But it said it right in there. It's a post-residual, right? Post-void residual. Post means after, void means void, pee, residual, what's left after you pee. Okay? So you would instruct the patient that after you void, I'm going to put a catheter inside you. Okay. And how much urine would be an acceptable amount of urine to be left in the bladder after the patient has just voided? Does anybody know?
30 mLs.
So somewhere between 50, maximum 100. Anything more than that, you got an issue. Probably going to tell you, the doctor's probably going to tell you to leave the catheter in until we figure out why they're not emptying their bladder. Okay, so that's that. We've got increased intracranial pressure disorders, clinical manifestations, 38%. Does everybody recall having seen that topic multiple times on the adult med surge?
Yeah.
Yeah,
I just
remediation.
know when I see ICP, I think about cerebral spinal fluid.
But it's not, but that's okay. So here's the problem, and I'm going to try to make this as clear as I can, and I'm begging you guys, listen. Every topic that's on the other proctored exams and on the predictor practice A and B is on the predictor. So if you remediate that other stuff the way you're supposed to, and you understand the content, when you see the question about the content, different question, same content on the predictor, you'd get it right. You understand? You understand? Why I keep yelling about remediation, remediation, remediation is the key. That is the key. It is the only key. There's no other way to study. No flashcards, none of that stuff is going to work. You need to remediate. I don't know, if somebody can tell me a different way to explain this that would make it more effective, I would be forever in your debt. Okay? I want to make sure that everybody understands what I'm saying. Remediation is the only key to success. It's so simple, right? Because the topic of increased intracranial pressure and clinical manifestations has repeated itself multiple times in previous ATI tests. And I keep reading remediation that talks about causes of intracranial pressure, because when you're looking this stuff up, people are like, I got to get this done, this remediation, pain in my butt. And they go to ATI, and the first thing that they look at, they're like, oh, here you go. And then they just copy and paste it, which drives me out of my mind. It makes me sad. And still can't tell me anything about increased intracranial pressure. Can anyone tell me what a clinical manifestation of increased intracranial pressure is?
A headache.
Don't you have the
A
stuff
headache.
that comes out your nose, the clear fluid?
That's cerebral spinal.
So not necessarily. So increased intracranial pressure is usually secondary to either cerebral edema or tumor. I mean, there are multiple reasons why there would be increased intracranial pressure. I am going to find some kind of a cheat sheet or a synopsis or something to put up on Teams, so that the next time I ask this question, people will be able to answer me. Okay? Even though it's been coming up and coming up and coming up before. So do you guys, do you get what I'm saying? Why I keep saying how important the remediation? Because if you remediate that adult med surge and that farm and that practice A and B predictor, you could get a 90-something on the predictor. That's the key. It's that simple. Okay?
Ms. Mary, do you see me typing in the chat box?
I see you.
Okay.
Yeah. And I mean, yeah. I mean,
You asked for manifestations, right?
they are some of the manifestations. Yeah, absolutely. I'm going to put a cheat sheet up. I mean, headache, the problem with things like headache and vomiting, they're very vague, and hypertension, and they don't always have hypertension, because it's just cerebral edema, or it's a brain tumor, which doesn't affect pressure systemically at all. So I'm going to get a cheat sheet for everybody, promise. This one, 29%. Diabetes mellitus management and complications, identifying manifestations of hypoglycemia. I'm going to cry. 29%. Hypoglycemia. Cold and clammy. Give them candy. Anybody? What happened? What are manifestations of hypoglycemia?
Diaphoresis.
Diaphoresis, they're sweaty, they're clammy, right? They're cold and clammy. What else?
Rapid pause.
Hungry?
No, that's no. So that's high blood sugar, right? So
Oh, you said hypo?
hypoglycemia.
Oh, sweating. I'm sorry.
Right, they're sweaty, cold and clammy. They're cold and they're sweaty. What else?
Low blood
Weight
pressure.
loss.
Irritable.
Rapid pause. Frequent bowel movement. Difficulty sleeping. Muscle weakness.
Irritability.
No.
I put shaky, irritable, confused,
Right, tremors, right?
tachycardia.
Yeah,
Yeah, that's why I
tachycardia,
put shaky.
confusion. Right. I mean, and then if we don't check their sugar or we don't do anything, they're going to slip into a coma and become unresponsive. Right? I don't know where these other things are coming from, right? I mean, so when we talk about hypo and hyperglycemia here, let me see, did I put this up? I think I did. Hypoglycemia. Let me share my screen. They're sweaty, they're pale, they're irritable. You know, oh, that's, you know what, and I'm a liar. So polyphagia with hypoglycemia, polydipsia, and polyuria. With
That's why I said
yeah, hyperglycemia, polydipsia, polyuria. So 2 of the P's with the hyperglycemia, 1 of the P's with the hypo. Sleepiness, lack of coordination, right? It's tremors. They're the big ones, right? They're like shaky, sweaty, confused, irritable. So nothing to do with their bowels or any of that. And then with hyperglycemia, hot and dry. So they're not sweaty, but they can be like flu-like symptoms, feverish, hot, right? Dry mouth, they're thirsty, they can be weak, they can have a headache, visual disturbances, not just blurry vision, double vision, sometimes they'll complain of, frequent urination, right? So make sure you understand, I'll put this up and I'll put up, I think I have the endocrine NCLEX points, which is a great little tool. And I really thought I put that up, but maybe I didn't. There's so many now. I don't know what I gave you guys and what I didn't anymore. Stop sharing. Come on. Here we go. Okay, so this is a little, it's more of a cheat book than a cheat sheet. Endocrine NCLEX points, make it a little bit smaller, okay? And it's got really good synopses of the endocrine things like SIADH versus diabetes insipidus, hyperthyroidism and thyrotoxicosis versus hypothyroidism, right? There's Addison's versus Cushing's. Addison's, Cushing's. There's diabetes mellitus, right? And the things that they have written in blue, more common in type 1 diabetes versus type 2 diabetes. They give you an overview. They give you your assessment, you know, what you should be assessing for, what the therapeutic management is of, what sick day rules are, complications that can occur. And they even go into hyperglycemic, hyperosmolar, or non-ketotic syndrome, which is typically occurs in type 2 diabetics, versus diabetic ketoacidosis, which more typically occurs in type 1 diabetics. He gives you a little chart here. And the thing that's helpful about this is that, like, you don't need to worry about growth hormone, but antidiuretic hormone, you know, it has to do with insipidus and SIADH. Your T3 and T4, you know, has to do with your thyroid. Glucocorticoids and cortisol has to do with Addison's and Cushing's, and insulin is, you know, from the pancreas, has to do with diabetes mellitus. Goes over radioactive iodine test, all the different testing that's done. I mean, there's a little bit more here than you need to know, but if you go on and get your RN, this will come in handy, I promise. Oh, there's an example of a Trousseau's.
I was supposed to say that.
Yep, Trousseau's. Latent tetany after the inflation of the sphygmomanometer cuff. And it's a sign of what? What's it a sign of?
Low calcium.
Hypocalcemia.
Hypocalcemia.
Or hypomagnesemia, right? Just remember, when you think potassium, you think muscle. When you think calcium and magnesium, you think nerves. All right, so I'll put this up for you guys as well. Oops, no, not that. What else do we have? Oh, let me stop sharing for a minute. Emergency nursing. Priority action for a client experiencing respiratory distress. So if a client is experiencing respiratory distress, what is the first thing?
Oxygen.
First thing.
Check for pulse.
The first thing you do.
Lift the head up.
Elevate the head of the bed. Make sure they're in a fully upright position. Oxygen, right? You should put a pulse ox on them, right? You might want to get ABGs on them. Assess their lungs, respiratory rate, and quality of respirations. Are the respirations labored? Do they have adventitious breath sounds like crackles or rhonchi, right? So you guys, you need to know, those are the basics. That's clinical stuff. But anyway, I don't know what the question was, but 40% got that one right. So, you know, when it comes to what's the priority action for somebody who's in respiratory distress, is you want them to be able to breathe, right?
Yes.
Yeah, I mean, I don't know, again, don't know what the question was, but all I can say is, you know, if somebody is in respiratory distress, you have to choose the answer that's the best answer that you have to pick from. And if it's, you know, elevate the head of the bed or give them oxygen, check their pulse ox or get ABGs, which brings me to acidosis and alkalosis. So, and that was another one that was a very low general, 30% expected lab values. When it comes to ABGs, arterial blood gases, number one, they are drawn by a respiratory tech. We don't typically draw from arteries, okay? They are used to identify severe respiratory issues. It's usually a COPD, right? Or somebody, you know, with pneumonia, those kinds of things. We're looking at the gas that's in their arterial blood, right? And we've got ABGs. You've got your pH, 7.35 to 7.45, partial pressure of carbon dioxide, which is 35 to 45, your bicarbonate, which is 22 to 26, and then your partial pressure of oxygen, which is 80 to 100. ABGs don't have to be hard. The first thing you look at is the pH. If the pH is low, it's acidosis. If the pH is high, it's alkalosis. And then, is it metabolic or is it respiratory? You look at the partial pressure of carbon dioxide. If that's elevated, they're in respiratory acidosis, right? Because carbon dioxide is an acid. right? And you look at the HCO3, which is the bicarbonate, which is controlled by the kidneys, which is an alkaline, right? So I'll put up the ABG ebook. But respiratory acidosis is easy to identify. You're going to have a low pH and an elevated PaCO2. This is where I drop the mic. Okay. So that's that. I'll put up the ABG ebook that I have. And let's see what else. Any questions so far?
No.
Nothing. All right. Any questions about anything? Doesn't even have to be like what I'm talking about. It could be anything else. Oh, what's this one? Recognizing a thyroid storm. 45%. What's a thyroid storm? Thyrotoxicosis or a thyrotoxic crisis. They almost sound alike, don't they? Thyrotoxicosis or a thyrotoxic crisis, which is also known as a thyroid storm. Anybody? What is it?
It occurs after you removal of your thyroid.
Well, that it can.
Tachycardia.
It can. Okay.
It's
So,
from
but first,
T4s
so
and
what I
all
want
that.
you guys to do is think to yourself, I'm the patient, right? How do you explain it to me? Somebody, be a
It's
nurse.
from hyperthyroidism.
Okay, so wait a minute. Angelique, go ahead. Go.
It's from hyperthyroidism.
Explain.
Right?
Okay, what's that mean, honey?
So when your thyroid spirals out of control, it'll cause you to have a thyroid storm, which is pretty much like an increase in everything. So your temperature, your heart rate, your
So in
blood
other words,
pressure.
what do you mean about my temperature? I'm going to have a fever,
Yes, elevated temperature,
right?
elevated blood pressure,
Right?
elevated heart rate.
Come on, girl. You're batting 1,000.
Elevated calcium.
Elevated respiratory rate.
Respirations,
Everything's off the chain, right?
everything.
Okay.
Yes.
Okay. And so what do you do for me? What are you going to do?
So
Who are you going to call?
treat not the Ghostbusters.
Not the
So you would treat
Ghostbusters.
that- so you would treat that hyperthyroidism. So
No.
normally they give you-
But what's the first thing, if I come into your ER and my blood pressure is 200 over 120 and my heart rate is 130 and my temperature is 104.8, what must you do?
We need to get some
You
meds.
do know, I know you know, you know. Somebody.
Beta blockers.
Do I?
Beta blockers.
Okay, beta blockers, why?
So the heart rate, bring down the blood pressure.
Right? And what else? What else you gonna do?
Antipyretic for the fever.
Thank you.
Support.
Right, you're gonna treat the symptoms so I don't drop dead. Don't let me drop dead, right? Treat the symptoms, and then we have to say to ourselves, why did this happen, right? Why is her thyroid out of control? And as Jay Swizzle said earlier, one of the things that's the weirdest thing for people to get is that post-thyroidectomy. If you have a patient that has hyperthyroidism, and it's gotten to the point where we've tried methimazole and or propylthiouracil, and it has not worked effectively, then the last ditch effort is we will give you radioactive iodine, which will destroy some of the thyroid tissue, and then we will take you into surgery and take your thyroid out. You will be on levothyroxine, thyroid medication for the rest of your life. But sometimes, if we don't shut down the thyroid activity before we remove it, a complication post-thyroidectomy is a thyroid storm. And people are like scratching their heads going, but wait, her thyroid's out. If we did not sufficiently suppress the thyroid activity before we took the thyroid out, that T3 and T4 is rolling around in your bloodstream at really high levels, and it doesn't start to rear its ugly head until the anesthesia wears off. And then next thing you know, boom, blood pressure, boom, heart rate, boom, fever. Right? So again, with that, the thyroid's out. Now we just have to treat the symptoms and wait it out. It's going to pass. Right? So we're going to give beta blockers and antipyretics and maybe a cooling blanket or whatever. Get the temperature down, get the vital signs down, get the patient stable, and wait for it to pass. And speaking of a thyroidectomy, what is another potential complication post-thyroidectomy? What's on either side of the thyroid?
Your parathyroid?
Parathyroid glands. And so they're itty bitty. What if they get nicked or accidentally removed when we're taking the thyroid out?
Graves' disease?
So Graves'
Your blood
disease.
sugar, right?
Hypocalcemia.
So Graves' disease is an autoimmune disorder that causes hyperthyroidism. Your parathyroids are on either side of the thyroid gland. They're teeny tiny, and they control a hormone called calcitonin. Calcitonin is the hormone that controls calcium in your blood versus calcium in your bone. Keep it balanced. How much calcium's in your blood, how much calcium's in your bones, okay? If the parathyroids get nicked or removed accidentally, you're going to suffer hypocalcemia. Serum blood calcium levels will start to drop. What's this test?
Show something.
Come on.
That's what it says. Oh, sure.
Schwostek. Schwostek.
Oh.
Schwostek sign. Tap the facial nerve, the jaw twitches. And then the tetany. Trousseau's sign. Both of those are nursing tests that you guys can do to, if you elicit a positive, that means that your suspicions are correct. The patient's suffering from hypocalcemia, secondary to that thyroidectomy, and we probably nicked or removed the parathyroids. If your patient complains of numbness or tingling after the surgery in their extremities, their fingers, hands, feet, toes, probably hypocalcemia. You would then do a Schwostek's test and a Trousseau's test to see if they're positive. Okay? Is your brains hurt yet or what? You guys are too quiet today. I can't. All right, I'm gonna stop the recording. The baby's even had enough. He's like, eh. Until the
That's
next
why I was
boot camp.
using a chat